The second thing is that I just ask you how sort of consciously competent you think you are. Are you thinking, oh, I see that problem and I need to do this? Or are you just getting round like you'd be driving your car from A to B and not really thinking what you're doing in the process?
So on that note, I've started using the scope guide here. Yes. For the first time.
Yeah.
And there are instances where I see or where I feel a problem forming or a loop forming or a buckle, and which I noticed myself that I anticipated it.
Yeah.
So sometimes I do feel a problem coming up, and I see that the scope guide confirms my suspicion that it is going to an spiral or an alpha reverse alpha. But still sometimes, or quite often, I run into a problem and I need to look and analyze the image that I get on the scope guide to see what's going on and to try something and see if it resolves or if it gets worse.
Okay, so where I'm going with this is that if one of your objectives is to be proactively competent, if you like, to achieve that, I think it's better to be conscious competence. I think with practice, we flip between the unconscious and the conscious competence zones at the bottom there of the whiteboard. When it gets a bit difficult, we have to move into the conscious competence zone to sort of work out what's going on. But if it's not too difficult, we're sort of chatting to the nurses or whatever, not really paying much attention to what we're doing, like when we're driving a car very often. And, you're not really thinking about what you're doing, it's just happening. And to achieve that, or for me to know that you are there, I want to go, I will at times ask you questions, and that the question would usually be, what is the problem? Not what is the solution. So can you try your best, if I say what the problem is or what are the problems, if you can define all the problems that you have? If you remember, I talked about this last night, and then we can move on to the solutions. And then, as I said last night, the execution of the solutions, and that's where your left hand and the umbilicus comes in and your tip control comes in.
Just before we get there, Roland, thanks for that nice educational contract. We just also talked about ground rules locally. We talked about the fact, having done this one time before, that there are situations which you guys in remote have got no idea about because of the fact you can't see the patients here. So we talked about hierarchy of decision making and hierarchy of stop, and the local trumps the remote. And so we've said that to the guys here. So if they're listening to me and ignoring you, then please don't be offended. That's just because something locally is going wrong that you guys cannot see and cannot appreciate from where you are. And I think that we previously also talked about that as a patient protection mechanism for these virtual live experiences.
Absolutely. So 100% patient trumps everything else. So if you have any concerns about the patient, that's absolutely no problem. It's helpful if you have time just to explain what's going on, and you might say, I'm taking control now, David.
Yeah.
All right. So we know, and then if you want to give the training back to us, it's a bit like taking controls of an aircraft when you're training. There is you have control now, or I take control back. So
sorry, it's probably worth saying, Roland, in terms of the patient aspect of all this, the reason for not just biopsying that is because it's small and because of the inconvenience to the patient of having to come back. Yeah.
No, I don't think it should be biopsied now.
Sorry, I interrupted you, Roland.
No, but I was just going to say that.
So I would actually try to inject it below and push down when it comes up.
John made the point.
He made the point, yes. I think, I can't remember, he's always making the point, but the point that for the SSLs, it's a good idea to inject
totally agree.
Yeah, to define.
So watch out, stop, Sander. So what's happened there is that everything's lifted apart from what you wanted to lift. So the reason why is because it's the base of the cecum. There's been a resection. It's fibrotic. So why don't you just go a little bit in the kind of depression that you see there and try to get that to lift? It probably won't. Okay, good. Stop. But what we're trying to use this for is not so much cutting at the moment. It's just assessment, right? So why don't we zoom in there, have a good look at it now. And do you know? Are you familiar with the appearance of a sessile serrated lesion once injected?
They look a bit more pinkish.
They do. They look a bit more pinkish. I mean, for me, there's something there. I don't know what John thinks. So that looks very like a sessile serrated lesion now. I think I agree with John that it's significantly more clear. Beautiful underwater imaging. Xander's really good at this. He's really drunk the Kool-Aid of underwater imaging, Roland. So look at that. I think that's something. I think we should just cut it off. What will you use to do that?
So John and I were just having a conversation.
And probably just a 10 mil.
Sorry, Roland. We are listening.
So John was just whispering in my ear. He'd just take that off now. He wouldn't give any more injection.
Agree with that totally.
Yeah.
So that's what we'll do. So maybe we can use a little cold snare polypectomy here, Roland, if you permit it, or.
Yeah. No. So I think so that we the collective view in Cheltenham is that you should cold snare that now.
I think that would also be the collective view of the ESG. So.
Well, that's good, isn't it?
Isn't it good? We're on the same page, yes. Even despite Brexit.
So Xander, the first question we asked then is we just asked the trainee to say what it was like. How was it for you? What was there anything you particularly took away from there, Xander?
Yeah. So there are a few things that I written down that I in fact will remember. But there are specific moments in the colonoscopy. I don't know if that is the point of this question already. More general, in the mid-transfer, I had like a moment that my movement sped up.
Yes.
That was probably maybe not completely cognitive overload, but just a bit of irritation due to the murky fluid. But there was really no point in being then a bit rushed or a bit annoyed. So maybe have to be aware of that.
Right. So I think the first thing is awareness, because very often you speed up in that situation because you're stressed out and it's difficult. And so all your attention is trying to sort the problem out and you don't realize. Now, I think it was probably a bit more than irritation of the fluid, but let's just say it was irritation of fluid. So at that moment in time, how critical was it to have good tip control?
Well, that was probably one of the most or the most difficult part of this particular colonoscopy.
Yes, it was the moment where you needed to have optimal tip control. And you lost that because you were trying to do it too quickly. Yeah. So I think the take-home lesson is what? So if you were to summarize what the take-home lesson is there, what is it?
Slow down and keep the tip control and the speed of the colonoscopy always in the back of your mind.
Okay. So Xander, I'd like you later to go back to the video and look at the video and see what happened when you applied clockwise torque when you were in the proximal colon. And I want you to tell me later what you saw. But we're just going to, can you see the screen that we're sharing at the moment?
Yeah, I can see the whiteboard here.
So can you see that screen, Xander?
Yeah.
So you see the image at the top there, the scope guide. That is the image that was happening at the time. So John got a screenshot there of what was going on. So just describe the scope guide briefly.
So the splenic flexure is moved a bit anteriorly, but in one plane, and then the transverse colon, the mid-transverse colon is going down and posteriorly.
It's going posteriorly, okay. So John has very helpfully just drawn what that looks like. So the grey is the bit of the colon that you can't see. And basically what you need to do is pull back as you did, and then you need some anti-clockwise torque, and you can see that round here the effect of the anti-clockwise torque is to pull the splenic flexure forward, and it drives the tip of the scope forward. But you need exquisite tip control to make this all happen, and you just sped up at that point and made life very, very difficult for yourself. So we just wanted to show you that, just to embed that in your conscious competence, and this is really important. And just occasionally you'll need some support with hand pressure in the situation to enable you to do the procedure. In fact, you didn't need it